Hello everyone, I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Today we have an important lecture about the Antenatal Corticosteroid Guidelines, according to the Royal College of Obstetricians and Gynecologists, published in February 2022. So we are talking about antenatal corticosteroid to reduce neonatal morbidity and mortality. What is the role and the benefits of corticosteroid? What are the risks? What are the dose of corticosteroid? Which gestational age the corticosteroid can be given and give the most important benefits, and all about antenatal corticosteroid. Okay, will be covered here. So let us start with the benefit of antenatal corticosteroid. Is there is benefit? Yes, there is benefit to decrease the perinatal and the neonatal deaths and respiratory distress syndrome. So giving our antenatal corticosteroid, yes, in cases with preterm birth, reduce perinatal and neonatal death and respiratory distress syndrome, and this is grade A recommendation. Next, what about women planning for cesarean section between 37 weeks and 38 weeks? Should I give them antenatal corticosteroid or not? Because some obstetricians give at this time, okay? Really, an informed discussion should take place with the woman about the potential risks and benefits, of course, of antenatal corticosteroid. So, nothing without risk. So, you should discuss with her the benefits and the risks. Okay? This is grade B recommendation. Okay, although antenatal corticosteroid may reduce admission to the neonatal unit for respiratory morbidity, and this is proved in many studies, still it is uncertain if there is any reduction in respiratory distress syndrome, transient tachypnea of the newborn, or neonatal unit admission overall. Okay? And antenatal corticosteroid may result in harm to the neonate, which includes hypoglycemia and potential developmental delay. And this is grade B recommendation. Okay, what about the gestational age? The best time to give antenatal corticosteroid and got the benefit of this corticosteroid between gestational age between 24 weeks and 34 weeks plus 6 days gestational age. Okay, so corticosteroid should be offered to women in whom imminent preterm birth is anticipated. Okay, this preterm birth may be established preterm labor, preterm pre-labor rupture of membrane, or planned preterm birth by decision of obstetrician, because there is risk. So he decided to terminate pregnancy early. Okay, so whatever the cause of imminent preterm birth, yes, the best time and all guidelines recommend to give antenatal corticosteroid intramuscular in the gestational age between 24 and 34 weeks plus 6 days. Okay? Okay. So below that and above that, there is controversy. This is the best time, and this is approved in all guidelines that it is very important. Okay? And the benefits outweigh the risks. So what about before 24 weeks? Is there any benefit? Yes, there is benefit as regard to the baby, but still this baby is too young. This gestation age is too young, and the prognosis may be not very good. So we should discuss with the patient all circumstances and the preferences and tell her about the complications, okay, and the possible result of this pregnancy. Okay. What about the gestational age between 34 weeks and 36 weeks plus 6 days gestation age? So obstetrician and women should consider the balance of risks and the benefits of corticosteroid in women in whom imminent preterm birth is anticipated. And this is grade D recommendation. Okay? Okay. So what about the optimum dose and route of administration? The dose is 24 milligram dexamethasone in total, and it is divided into two doses, 24 hours apart. So you should give the patient 12 milligram dexamethasone, and after 24 hours, give another 12 milligram dexamethasone intramuscular. This is the course of dexamethasone, and this is grade B recommendation. Is there is an alternative to dexamethasone? Yes, betamethasone. In the same dose, 24 milligram betamethasone, sodium phosphate and acetate max, is given in two doses, 12 milligram each one, 24 hours apart, intramuscular. So the total dose is still 24 milligram, either dexamethasone or betamethasone, divided here in two doses, 24 hours apart. But in case of dexamethasone, I can give the same two doses, 12 milligram, 24 hour apart, then another 12 milligram intramuscular. Also, I can give more divided doses, 6 milligram every 12 hours for 4 doses. So the total is still 24 milligram. This is as regard dexamethasone. So dexamethasone has two doses, both of them 24 milligram, but one of them divided into two doses and given intramuscular 24-hour apart. And the other one divided into four doses, each one 6 milligram every 12 hours. This is as regard dexamethasone. But betamethasone given in one regimen, 12 milligram intramuscular, then after 24 hours, another 12 milligram intramuscular. This is as regard the optimum dose and route of administration. Can I give the patient oral or transplacental corticosteroid? No. So, oral or transplacental administration is not recommended. And this is grade B recommendation. So, only intramuscular dexamethasone or betamethasone should be given. What about the duration of efficacy after administration of antenatal corticosteroid? After 48 hours from giving the corticosteroid, this is the most efficient time, okay? So, antenatal corticosteroid use reduce neonatal deaths when the first dose is given within the 48-hour period to birth. Period to birth, okay? And this is grade D recommendation. Benefits are also seen when the first dose is given within 24 hours of birth, and the antenatal corticosteroid should still be given if birth is expected within this time. So, if you asked me, the lady may be delivered within 24 hours, should I still can give the dexamethasone and she may be delivered within 24 hours? Yes, and she will get a benefit. So, the best is the passing of 48 hours from the first dose. But if the imminent preterm labor happen within 24 hours, still there is benefit of giving dexamethasone. So don't avoid to give dexamethasone because there is short duration. No. Within 24 hours, also you should give dexamethasone or betamethasone. Okay? Antenatal corticosteroids are most effective in reducing respiratory distress syndrome in pregnancies that birth between 24 hours and 7 days of administration of second dose of antenatal corticosteroid. And this is grade D recommendation. What about in multiple pregnancy, like twins, triplets? Should be offered targeted antenatal corticosteroid for early birth in line with recommendation for single two. There is no difference than single two. Okay, this is grade D recommendation. What about women with diabetes mellitus? Is diabetes mellitus contraindication to give corticosteroid to enhance fetal lung maturity? Diabetes shouldn't be considered an absolute contraindication to antenatal corticosteroid for fetal lung maturation. And this is grade D recommendation. So I can give antenatal corticosteroid in diabetic women. So in women with diabetes who are receiving corticosteroid, additional insulin should be given according to an agreed protocol, and the close monitoring should be undertaken. We know that giving corticosteroid in diabetic women will cause increase in blood glucose level. Okay, so I expected that to happen within 1 week or 5 days from giving the injection. Okay, so I should increase the dose of insulin to control blood glucose. So what is very important, to monitor the blood glucose level. So give the patient the corticosteroids for enhancing lung maturity, and at the same moment control the blood glucose. You may add insulin for the original dose. Okay, this is grade D recommendation. Okay, so if I have a woman with diabetes, okay, and undergoing planned cesarean section between gestational age 37 and 38 weeks plus 6 days, okay, an informed discussion should take place with the woman about the potential risk and benefit of the course of corticosteroid. Okay, as I said before, all guidelines recommend the gestational age between 24 and 34 weeks plus 6 days. But here we are talking about 37 up to 38 weeks. We should discuss with the patient that there is risks and the complication, although there may be some benefits, but also there is risks. Okay, and you should also concentrate on certain risk, which is neonatal hypoglycemia. Okay, and this is grade C recommendation. So what about pregnancy complicated by either preeclampsia, hypertension, IUGR, antepartum haemorrhage? Should I delay the birth although there is maternal or fetal risk, so that the corticosteroid reach its maximum benefit? No, you shouldn't delay delivery if there is risk to the mother or to the fetus. So birth shouldn't be delayed for antenatal corticosteroid if the indication for birth is impacting the health of woman or her baby. And this is good practice point. In grading, this good practice point. Okay? So if there is impact on the health of the woman or her baby, don't delay birth. Okay? Some doctors may believe that if they delay birth to make the corticosteroid, to give a chance to the corticosteroids to have the maximum effect, as I said before, 48 hours. But what about if there is risk to the mother or to the fetus? Okay, so don't don't delay the birth if there is harm to the mother or to the fetus. Okay? And this is a good practice point. Okay? What about pregnancies complicated by hypertension? Can I give antenatal corticosteroid? Yes, a course of antenatal corticosteroid should be offered if planned early birth is necessary for hypertension in pregnancy. Okay? This is grade B recommendation. Hypertension with pregnancy, preeclampsia, and so on. What about pregnancies complicated by intrauterine growth restriction? If imminent preterm birth is likely, the course of antenatal corticosteroid should be offered to women whose babies are thought to be either small for gestational age or to have fetal growth restriction. But women should be counseled about the lack of evidence to guide care. And this is grade C recommendation. So in IUGR or small for gestational age, you should give antenatal corticosteroid. Okay. Preterm, prelabour rupture of membrane. In these cases, can I give antenatal corticosteroid to enhance the fetal lung maturity when the preterm birth is imminent? Yes, antenatal corticosteroid should be offered in women with PPROM who are at increased risk of preterm birth, and this is grade A recommendation. The best grade for recommendation is grade A, of course. Okay, so you should give her antenatal corticosteroid in women with PPROM. Okay, what else? There is currently limited evidence to recommend repeated courses of antenatal corticosteroid. If a woman remains at imminent risk of preterm birth 7 days after administration of antenatal corticosteroid. What is this stop? We have a case with preterm prelabour rupture of membrane, okay? And you give to her the antenatal corticosteroid like dexamethasone. You give her the total course of 24 milligram, okay? And then 7 days passed and no birth happened. So there is still prolongation of pregnancy. Should I have to give her another course of corticosteroid? This is the question. Okay. There is limited evidence to recommend repeated course. So there is controversy about this point. There is limited evidence to recommend repeated course. And you should know, repeated course associated with more risks and more complications. So there is still limited evidence to recommend repeated course of antenatal corticosteroid. However, further course, this if you give a second course, for example, may reduce the need of neonatal respiratory support. Okay? And this is grade B recommendation. What about risks associated with administration of antenatal corticosteroids? You should discuss with the patient that there may be some risks like maternal abnormal glucose tolerance test, like lower birth rate, like neonatal hypoglycemia, like decreased length of the baby, decreased head circumference, maybe developmental problem. Okay? So you should counsel the patient about the risks and uncertainties surrounding the evidence of antenatal corticosteroid treatment. And this is a good practice point. What else? An institution should use standard guidelines for the assessment and the management of neonatal hypoglycemia in late preterm or early term newborn who have received recent antenatal corticosteroid. So, if still some obstetrician insist on giving antenatal corticosteroid in early term or late preterm pregnancy, you should expect the newborn may have hypoglycemia. So, special care should be given to this neonate to diagnose the hypoglycemia and manage it. This is the needed information to be present between all obstetricians. If you insist on to give the early term and the late preterm antenatal corticosteroid, okay, you should expect that neonatal hypoglycemia may happen. You should diagnose the neonatal hypoglycemia, of course, by pediatrician, and should be managed properly. This is very important, okay? And this is a good practice point in grading. This is the end of my lecture. This is my published book on Amazon, textbook of obstetrics, textbook of gynecology, contraception handbook, and the multiple choice question book, and medical disorder in pregnancy book. This is my site on Amazon, and this is my site on YouTube channel, and this is my site on Blogspot. Thank you, everybody. My best wishes for all of you.